we've got, okay, calling the meeting to order at 9:03. Roll call, we've got Rich Rydell remote on Teams, and we have Shelley Stelzner, Vice President, online as well from the board. So if we can, let's rise for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Okay, great. All right. Move on to public comments. Do we have nobody in the room? Do we have any public comments online?
No, we do not.
Nothing online?
We do not receive any via email either.
Okay. So moving on to number 4, fiscal year 2025-2026 Seneca Healthcare budget presentation. Steve, you want to take over?
Will.
All right.
And Ethan here. What is it, and we'll go.
Before you, Steve, Sean, who is present?
We have Jerry in the room, and we've got Deborah for notes, and Ethan for IT, and Brady, our COO, and Steve.
Thank you.
Okay.
So let's open the
All right. Welcome. So for Rich, and am I allowed to acknowledge Jerry? Okay.
Yeah.
So for Rich, this is a familiar look. For Shelley, Shelley, did you go through budget last year? I can't recall. Okay. So Ethan, I'm gonna have you this is gonna be a interactive between you and I. Okay, just stop there. So what I've done is similar to what I've done in the past. I've done a trend of the key components of the income statement for Seneca. In the case of this presentation, I put the last 5 full fiscal years all audited, and then the current fiscal year we're in projected out through, or annualized or projected out through the end of its own fiscal year. In this case, for June 30th, 2025, we took February's actual 8 months ended February 28, 2025, and then just more or less annualized it out. There were a few things that we played with that we didn't annualize because there were significant one-time expenses, or the entire expense had been incurred within the February period. So anyway, it's a rough annualization. So here, if we look at the gross patient revenue, which is incredibly significant and important to us, I mean, that's an obvious statement, but in our case, it's really an important issue and subject conversation, not just for budget purposes, but for strategic planning going forward today and into the future. So gross patient revenue goes back to fiscal year ending June 30, 2020. Now, this was the onset of COVID. So I think it was March of 20 is when COVID, all the restrictions and panic, if you will, related to COVID. So when I say panic, I mean that people would actually start choosing to defer elective healthcare. The state said we couldn't do surgeries, things like that. And so that was the beginning of the impact on our patient revenue. And you can see that trend continued into fiscal 21, when that was our first full fiscal year of being under the influence, at least from our revenue perspective, of COVID. Then into 22, we started to come out of it. 23, we came out of it a little more. 24, we took a bit of a dip. We really had a big dip in our outpatient revenue. It's a topic of discussion during the year, fiscal year, at board meetings. And then, good news is that for, at least for February, or for February annualized, we have increased our patient revenue very nicely, the bulk of it being outpatient revenue. So Ethan, if you, and you guys, Shelley and Rich, just chime in at any time. Ethan, you're gonna just go to, okay, oh my gosh. Oh, there we go. I read the supplemental payments, I said, oh my God. That's out of order. Okay, so what this is here is this is the net patient revenue. So more or less, there's the same relationship that we saw with the gross patient revenue. Just a couple of notes here that if we go to, it's not here, but just for conversation purposes, for fiscal 24, 6/30/24, our adjustments to revenue were 31.87%. We're projecting for 25 it to be, well, I put in 30%. It'll probably not be right on the number, but I put it in for projection purposes. And then, as you saw, the budget's gonna be a little lower. So what's happened here is that, and we'll see it in our costs rising, since we have such a high percentage of Medicare population, over 50% of our revenue is Medicare, and is reimbursed on a cost basis methodology, that as our costs grow, we recapture some of that in our Medicare reimbursement. So even though we've had rising costs, we've had and not a large increase in net patient revenue, especially when we look at 23. We've been able to cover ourselves, if you will, through the way we're reimbursed for Medicare. And that continued into 25, and we're projecting it'll continue into 26. Oh, next slide, please, or bottom slide. Okay, here's what I was talking about with the rise in expenses. You know, you see kind of a I don't know what you want to call it, incremental increase from 20 to 21 to 22. Then we saw a big jump in 23. A lot of it related to the implementation of Cerner. And then we go into 24, another bump. 25, we're projecting an increase, but not as much. And we can look at the detail, and then we're looking at another increase in our expenses into the budget year. And this is where Medicare has covered us somewhat, in that we're getting over 50% of that expense growth, we're getting that reimbursed. So if we were just on high commercial, where we get a percent of billed charges, or Medi-Cal, higher amount of Medi-Cal where we're on fee schedule, then this would hit us a lot harder. So that's, I guess, one of the positives and the idea of the critical access hospital program. So Ethan, let's go to the next slide. And can you just slide down just a tiny bit, cut that header, and it's not gonna fit all in. Can you reduce, yeah, perfect. Okay, there we go. And then just slide it down. So it's kind of important to look at these two together. As I talk in the board meeting, salaries and wages and professional fees, specifically contract labor, are really intertwined, because it's our cost for staffing. Some of our professional fee staffing has shifted from a contract basis to a salary and wage basis. Mainly the clinic expense of staffing providers in the clinic, excuse me. So as you can see, again, we've had that incremental increase in wages, we've seen a growth in FTEs, we've seen a growth in average hourly wage. But what we've also seen is we've seen a decrease in the contract labor. And the big jump was when we went from 24 to 25, you see a very large decrease in professional fees, just under $1 million. And of course, then we see a corresponding pretty big jump in salaries and wages. So Ethan, if you want to keep rolling.
Steve, can you hear me?
Very well.
Yeah, so is there a slide? I went through these, I didn't see it. Is there a slide that includes the salaries for laborers and wages with benefits? Because benefits are really expensive, I know.
Yeah, they're expensive, but they run about 20%, Shelley. And
Okay.
it stayed pretty constant for us around 21%.
Okay,
We don't have a high pension expense, so that makes a big difference for us. And
okay,
there is, when we do the budget, when we do the budget portion of it, it does show salaries and wages.
yep. Okay, thank you.
Other expenses includes the benefits. And as you can see is, among other things, you can see has been pretty consistent, pretty steady growth, consistent with, the other categories of our revenue, our expenses and everything kind of growing at the same rate. The bottom line, the bottom slide, and this again is how I do the financials on an interim basis. So they're, to me anyway, they're a little more meaningful, is I take the supplemental payments out of operations so we can get a true idea of our operations. And of course, also give us an idea of what things would look like without the supplemental payments, which is, a little scary, right? And, so that bottom one there shows that back in 2021 and 22, one of the reasons we had lower losses is that's when we were receiving the COVID provider relief funds. And that did amount to millions of dollars for us. It really saved our bacon as far as us being able to continue to operate without having to worry about expenses if revenue was dropping as it did. And it actually, I hate to say it, we kind of turned a profit on COVID. So then we got back to normal in 23, and then 24, we had a spike in our loss, and that was mainly related to what I talked about, that we had the dip in the income previously. And then 25, we've had a recovery in our dip in our revenue, patient revenue. And then 25, we've had a recovery of our revenue to where we're looking at just under 4.8 million loss. So Ethan, if you want to go into, next two slides. And so here's that idea of the operating or historical operating margin. 20, 21, and 22 are like artificially reduced because of that one-time infusion of federal funds. And then we got back to more where we normally lay is in the somewhere above 20% loss from operations. And that ratio is just simply is the profit you have divided by total operating revenue. So in our case, we actually have a loss, so our margin's negative. Again, we had the spike in 24, a little bit of a recovery in 25, and then to spoil the end of the movie. Let's see what we have here. We're projecting pretty similar to 23. We're projecting 22.6 for our budgeting 22.6. So similar to 23, slight improvement on 25 and a, good improvement on 24. Here's the historical non-operating revenue. Essentially what you have here is you have, taxes, our property taxes we assess during this period of time. It's been between 650 and 800,000. And also we have our investment income, which run around $200,000. And then also we have donations in here as well. And so you can see real consistent. 23, we had a big donation year, over $500,000. And then otherwise, everything's kind of been very consistent. We made a little more on the interest income as interest rates have risen during this time period. Ethan, one more slide. Okay, so supplemental payments. You go back and we looked from 20 through 25. They were pretty consistent between 20 and 23. The 21, 22, 1 year being 6, 1 year being 2.5, was related to when the state shifted from a fiscal year to a calendar year for rate range and all programs. And we got 18 months in 21 and 6 months in 22. And so then it went back to the 4.6 million. In 24, we received an increase in our rate range. It was the last year of California Health and Wellness and Anthem. And then in 25, we had the big increase, which was what we were able to negotiate with partnership, and they provided for a very large increase. And there was a thing with the matter with the HQAF and district hospital directed payment, the DHDP program, which is going to ultimately replace the HQAF part. There was the state failed to consider our nursing home days in the district hospital directed payment program. And so our friends at DHLF were able to move some money around and we were held whole. But what happened was there was only supposed to be a 6-month payment for the first year of the DHD program. And in fact, what they had to do to get us whole was pay us a full year. And we'll see the impact of that in the budget for 26, where we'll only be receiving 6 months of the DHDP thing. So we moved down to historical net income. We're projecting a big increase in income. Large part of it is due to the increase in the supplemental payment and supplemental payment there that you see. And we'll see the same relationship after we take out the IGT. So Ethan, if you want to go one more page. Okay, and do the same thing. You can, oh, perfect, thank you. So here, as you can see, there's a big jump in the intergovernmental transfer, which is related to the larger supplemental payment we received for rate range. And then it all translated down into we're projecting a profit of just under 2 million. Bottom line with IGT. IGT does not go into our income statement. It's an equity transaction, but it's still a cash transaction to us. So we need to look at our operations with that IGT considered, so that we can see this is our real profit. I call it on a cash basis, but it's the profit after IGT, which we need to consider because we had to put up that $2.9 million to make the rest of the supplemental payment program work. So that's what we're projecting for 2025. As you can see, it's a nice bounce back from 24, and that's again related to two things, is our increase in revenue and also our, the increase in the net supplemental payments, so. That's a historic run through, through Seneca's operations, the last 5 full years, plus the current year. And I think the takeaway there is our expenses are growing and they're not gonna stop. Everything's costing more. We have to pay our employees more. We have to pay certain contractors more. So expenses are just going to continue to grow. And so the only way that we really make that work is through revenue. Yes, we can control some expenses in some places, such as eliminating the use of registry or eliminating the use of locums physicians and using our own employees or directly contracting with the providers at a better rate. But generally speaking, we're looking at rising costs every year. We're going to be talking to the union as 2025 calendar 25 is the last year of our current union agreement. And so we'll be talking about what kind of an increase are we looking at in the next agreement. So, and I have a number in there for this year's budget, but something that we're gonna have to live with. We're gonna have to provide for some increase in pay. We can't keep up with inflation, but something. So again, the takeaway is expenses are growing and we're gonna have to find a way to minimize that growth as much as possible. And then also we have to find a way to grow revenue. So any questions or comments or anything about, you know, where we're at and how we got here before we dive into the budget?
No, thank you, Steve.
Okay.
Excellent job.
You know, I was thinking as I was doing this, I'm wondering if maybe graphs are in order with this historical trend so that we can see visualize the ups and downs. Shelley and Rich, what do you guys think? Maybe graphs would be better here?
I
don't
like
know.
graphs.
I
Yeah.
like graphs.
Yeah.
Yeah, I think it's just kind of save a lot of explanation where you can just see the ups and downs. You know, you can certainly see it in the numbers, but graphs really just tell a story in themselves. So yeah, I think I'm gonna play with that for next year. All right, Ethan. Okay, so this is just a conversation about the operating budget. Right now, when we met with all the departments, we came up with a couple capital items. They're relatively speaking minor. They do meet the capital threshold. So we haven't put anything in here as far as a request at this point. We did pull out anything larger in the as far as a capital item, such as finishing out the top floor of this building or the Lake Almanor Clinic building. One of the things is that by the end of this year, end of this next fiscal year, we're going to have to make our capital contribution, if you will, towards the purchase of the shared MRI. So we really are not in a position to be doing much as far as capital expenditures that aren't absolutely needed. Fortunately, we've addressed many of those issues. Some of it through the early purchasing, whether it's the enhancements to the surgery equipment or the new ultrasound machine. We've also done some repairs. We are looking at a potential fairly pricey, I mean, relatively speaking, less than $100,000 potential upgrade of the HVAC in this building, but we don't have a commitment or the actual numbers to that at this point. So right now we're just looking at operations. So here's kind of the story. Net patient revenue, 19,395,896. Other operating revenue. We really just don't have a lot of other operating revenue anymore. We used to have the QIP grant go through there. And back when we were receiving it, the provider relief funds went through there. So now it's just, there's just a very minor amount that goes through there. There's salaries and wages that does, make sure before I say that is just salaries. Benefits are included in other. So I'll break out, I think there is a slide that shows salaries and benefits, but so right now we're looking at an operating loss of just under 4.4 million. Non-operating revenue of just over $1 million, pretty standard. Property taxes, interest income, some donations. And then the supplemental payments net of 5,362,253. So the net income with IGT, as this budget is being prepared and presented to you, has a bottom line profit of just over $2 million. So let's
Steve,
go ahead, Rich.
is there a change in FTEs?
Yeah, there is. Yeah, we'll go through that in one of the slides. It was dedicated to talk about the FTEs. So let's go to the next one, Ethan. So the operating loss is a decrease over what we're projecting for fiscal 25. It's a decrease of just under $372,000. It's made up of multiple components. The first one is that we are projecting an increase in net patient revenue. And this is a combination of a increase of 1.2 million in gross patient revenue and an actual decrease in contractual adjustments. And we'll talk about that as related to the reimbursement percentage we're projecting for the budgeted year. So even though we're having a increase in net patient revenue, we're having a decrease in contractual adjustments, and gets us to a 1.5 million increase in net patient revenue. Just a very small increase in other operating revenue. Then here, we're projecting a 1.2 million increase in salaries and wages, and this one does include benefits. This figure does. We're projecting a just under $294,000 decrease in professional fees. Of this, the medical, there's a medical fee component, and another component. The medical fee is decreasing just over 93,000, and the other professional fees are decreasing just over 200,000. We're budgeting a $150,000 decrease in contract labor, and then a 388,665 increase in operating expenses. And there's detailed discussion about each of those as we go on. So those are the components of our operating loss decrease of just under 372,000. So Ethan, let's go down to the bottom one. Okay, so here's the discussion about net patient revenue. So as mentioned, we're projecting a $1.5 million increase over fiscal year, the current fiscal year, 2025. This is made up of a $1.2 million increase in gross revenue, and on a patient utilization basis, we're projecting a slight increase in long-term care from long-term care average daily census from 14.53 to 15. We're projecting a slight increase in the swing bed ADC from 0.44 to 0.75, and it doesn't look like much, but it adds up. An increase in annual clinic visits of 10,398 to 10,800. So on the swing bed, the big thing there, and we'll show it in the slides, is that we're recruiting a physical therapist to come work for us, and the sole focus of that physical therapist on arrival will be enhancing and developing our swing bed program to include patients in need of physical therapy, as well as the occupational therapy and IV therapy that we currently offer.
So Steve, this is,
Yes,
so regarding partnership, so there is no, there wasn't a discussion about anticipated cuts at all with, partnership or Medi-Cal?
um, we kind of bounced it around a little bit. I don't think they know any more than we do. That's what you're asking?
Yeah,
Um,
yeah, I am, budgeting for an increase, I'm just like, ooh, that's very tenuous.
Yeah, well, it's a fairly conservative, and maybe, hopefully I can demonstrate it to you. Let's, Ethan, I'm gonna start the bouncing you around. Can you go back to the agenda and where it says, go to this item? Or view item? And let's go to the, number 2 there. Okay. Yeah, so at a high level, we can see that the hospital, and I'm looking at estimated versus budgeted columns here, and this is the revenue, gross patient revenue. So pretty much inpatient revenue's flat. You can see the swing bed revenue there is that we're projecting. And this is not just the bed revenue, this is the swing bed patient, the swing bed revenue that we charge, plus any of the ancillary services that we provide. And you can see that we're budgeting for just about a $520,000 increase there.
Mhm.
2 lines down, long-term care revenue. That's the impact of a half-day census from 14.5 to 15. So you can see it's about
Mhm.
260,000. We have no reason to believe that we're getting a cut in our long-term care rate. That has never been discussed whatsoever at this point. And we're reimbursed extremely well for long-term care. If there was a cut there, that would be, we would feel that one. So, but that has not been on anybody's radar at this point.
Okay.
So if, Ethan, if we can, and then you can just see the combined outpatient. So if you can move, yeah, scroll down to the, it's, just start with page 3 of 7, hold on. 2 of 7. So here's our revenue compared year over year or current year versus budgeted. And you can see that the gross patient revenue is in total is going up 1.2 million, and there's all the pieces of that. The swing bed in this case is just the bed charge. So $370,000 we're projecting off of increased swing bed utilization. And then there's a smattering of the ancillaries down below. Let's see, we've got SNF is the 164,000. And then what else was the inpatient? That was it. So on an outpatient basis, surgery, we had budgeted to do, 212 procedures for this current fiscal year. We're only projecting out to do 189. This is between our general surgeon, Dr. Jensen, and mainly his endoscopy practice, and then the orthopedic procedures through Dr. Watson. We're budgeting 227 procedures for 2026. Dr. Jensen keeps saying he can do more, so we're gonna take another swing at it. And that would provide 162,000 in projected revenue increase. The clinic, just those extra days, increase, $121,000 off those extra visits, not days. The big push on the outpatient is MRI. You know, we stopped MRI last fall when the contractor walked away from us or whatever they did. And so we're gonna be reinstituting that, and our projection is we'll have, an additional $336,000 in MRI, and that's not a very aggressive utilization. So when that all comes down, it's 1.2 million. So, yeah. Projecting increases. That's
And
what I'm
that,
saying.
and how many days a month do we anticipate that we'll have MRI on campus?
Or essentially
Every week.
So 4 days a month?
Yes.
Okay.
And we budgeted that there's some days they're not gonna be here, or some weeks they're not gonna be here just because of the weather, and I think we went with 47 weeks or something like that. That they're gonna miss 5 days somewhere along the line or something like that. Things just happen. But yeah. And so I think that what we're seeing there is surgery. We felt we had the volume, it just didn't play out that way. So we feel comfortable going back to that, trying to create that volume. We have to create the clinic volume. We know it's there. We have the providers. We just need to do it. Long-term care, they're running full now. So, the only time they're not full is when a resident passes, and the time to replace that or refill that, to place that bed with a new resident. And so more or less, they're gonna be staying at a full occupancy with just those temporary absences. So I think they can even better 15, but we'll see how that plays out. In the MRI, you know, we know we have a historical volume that will support that revenue, utilization. So swing is really the one that, no pun intended, we're taking a swing at. So,
Yeah.
that's the one. We know we've had some swing utilization in the past, that could support that type of revenue volume and maybe even more. So that's the only one that's really kind of subject to some, well, I don't know kind of thing, but we have to go in that direction. Those beds are horribly unutilized, and we're paying staff that could be caring for revenue generating patients. We're paying them for empty beds. So at times, more or less. So that's the strategy. With this revenue growth and the inpatient utilization growth, I don't see it taking a big hit on our Medicare reimbursement. In other words, as we drive higher utilization, it absorbs more of the cost and it brings down our reimbursement. With the growth of the budgeted growth in expenses, I think we're gonna be kind of where we're at right now. So I think the reimbursement's reasonable. So I don't think this is a overly aggressive. I think it's a fairly conservative revenue budget. PT could fall through. PT could not happen. I think I could see that one dropping off, but I'd be very surprised if we don't hit everything else. Questions or thoughts? I'm happy to pull the swing revenue out. And we can just budget from that. We're still gonna be fine. Whatever.
Yeah, it's a gamble. It's a gamble.
Yes, it is.
Yeah, it doesn't push us into profitability, and the lack of it pushing us into non-profitability or unprofitable. But it truly is an investment we need to make. Those beds are
Right.
just utilized. And that's
Yeah.
something we can do. It's like when we talk about rural health and critical access, frontier health or whatever, it's, what can we do? What do we do well? Well, we do primary care, we do emergency care, we do long-term care. There's these other services that we can provide that we need to absolutely go after. And we get very, very nice reimbursement on it.
Yeah, Shelley, based upon, conversation with partnership and some of our provider partners, whether it's Enlo or Renown, if we can secure a PT that is good, I believe that this is a conservative estimate on swing, and Steve purposefully went conservative on this. There's such a huge need to be able to swing patients, especially locally. It all hinges on our ability to get a good PT provider.
Right.
And I believe
Right.
that these are pretty conservative numbers. So yes, it's a gamble in the sense that it's hard to find a good PT, but I think it's less of a gamble as it relates to the 0.75 that Steve's put into the budget. So it's really find the right person and we can build it for sure.
Right. Right. Okay. So, when a long-term care resident receives physical therapy services, at that point, does that patient become a swing patient?
Oh, that's kind of a complicated question. It depends what kind of physical therapy they're receiving, Shelley. Now, what the swing bed is in our hospital, it's the equivalent of a skilled nursing bed in like the rest of the world.
Okay, that's what I thought. Okay.
Our unit, our distinct part nursing home is licensed for skilled care, but we don't put skilled patients in there because it's always full with the custodial care patients.
Okay. Okay.
So if somebody has a skilled need, we would put them into a swing bed, yes.
Okay. That's what I thought. Okay. Okay. And then we'd be reimbursed at a higher rate from partners.
Yes.
Yes. Okay.
Well, not necessarily from partnership. Partnership, Medi-Cal really doesn't seem to come up with a lot of swing type patients. Yes, they'll come up with skilled patients, but those individuals are typically placed in a skilled nursing unit, not in a swing bed. Swing bed is really a Medicare program. So, we've had them here and there, but it very rarely do we get a swing patient that's not Medicare.
Okay. But the majority of our patients that are in custodial are partnership patients, correct?
Right now, all but one,
Yeah. That's what I thought. Okay.
and that's great. That's great for us.
Yeah. Yeah. Absolutely. Okay. Thank you.
Okay, any more discussion on revenue? From either Shelley or Rich?
Um, question, early on you mentioned how all our expenses have gone up. What about our charges? Will they stay the same?
Yeah. So where we're at with charges right now is we've done some adjustments over time. We know that there's some areas that we need to increase. We have a vendor partner that does our CDM review for compliance and also does it for a market compatibility or whatever, market analysis. And that's undergoing right now. So we anticipate that they're going to come up with some proposed increases I just couldn't get it into the budget right now, so there's a good possibility that we're gonna be able to bump some rates. We know the ER might be low, we know that, I don't know about pharmacy, but we know that, respiratory therapy might be low. Physical therapy might be low. Rich, the biggest problem we have with that is that we have we have price limitations within our contracts. So if we raise our rates above a certain amount, then it opens up the contract for renegotiation by the payer. So that might not be bad, but we have some really great contracts. What we can do is we can make it that our overall increases are over a certain percentage, or that our numbers are reasonable. So we'll just have to see what the numbers come in. I was thinking that we might be looking at a mid-year bump is what my thought is. So mid-fiscal year. But we've adjusted lab, we've kept up with lab and radiology, which are two of our highest volumes. It doesn't matter what we charge for the inpatient beds. It doesn't matter what we charge for the clinic necessarily, because of the high Medicare and Medi-Cal utilization and how they pay us. But that's, something we will look at, Rich.
Thank you.
Okay, any other comments or questions? Okay, so Ethan, if we can go back to the scanned PowerPoint, the number one guy. Yep, there we are. Okay, so I think that I think we covered like almost everything there in that discussion, so including the rates and utilization, same as 2025, just had the conversation about the actual rates. And everything else I think we discussed in full, so let's go on to the next slide. Okay, so here's a look back, same kind of idea of our clinic utilization over time. What happened was, based upon the number of years we put here, we dropped off 2019, which was a year where we had very, very good primary care utilization. We had over 11,000 total visits. You can see 20 dropped down. It was a combination of provider availability and COVID. And then it kind of got worse, very much worse, and then made a big bounce back in 24 as we brought providers on. And if you go to the next slide, Ethan. So here's how we went into this current fiscal year with a budget. Dr. Ware was kind of on her own, and these slashes here are done because maybe I need to add more rows or something like that, but Dr. Ware was winding down her practice. She had a closed practice. For this fiscal year, Heather Smith took over Dave Wall's practice. Dr. Russo came on and was in a provider office, but we also brought in two locums, one that worked in the walk-in and one that worked at the clinic. And then we also brought in Dr. Greeley in 2025. Lori Kohler had her own office. And then the walk-in was a transition away from Steve Hayden. And then that's when we brought in Sarah Finnerty to do our walk-in during the heavy summer months. And then Brady Haynes and team transitioned away from a dedicated walk-in provider for the remainder of the year. And then the specialty was combination of Dr. Jensen, Dr. Watson, telehealth. So that's what we budgeted. Well, here's what we're estimating can see there's a movement of patients across the allocation in the different areas, but the total kind of came out. During the fiscal year, we brought on Stephanie White as a nurse practitioner to work in Dr. Ware's office. Again, within Dr. Russo's, as we call it, physician office, there was Dr. Russo, Dr. Greeley, Dr. Hartman was in there as well. Then you have Lori Kohler. The walk-in went down when they went away from the dedicated provider in the walk-in clinic to the patients being seen by individual providers in their office or however they did it that particular day. But we stopped counting specific walk-in patients for this analysis. They were assigned to an individual provider and then the specialty providers. So as you can see, there's pluses and minuses all over the place. Bottom line is we're a little bit under budget. Now, as we go into 2026, and this is why I say we feel fairly comfortable about projecting an increase. One, we know that the demand's there, and two, we think Brady and his team have worked up a good strategy for meeting the needs of our public. So Dr. Ware, I guess, is probably gonna work till December, and that may be it. You know, Brady can speak to that more specifically, but we planned on having her for a half a year or so. And Stephanie White is already seeing a great number of patients for a new provider. It's very impressive. And she will probably assume some of Dr. Ware's patients since she's been working with her this time. So we look at that as almost like a provider and a half. And so we say, let's go 2,800 visits. Heather Smith at 2,000. She can hit that. She's more of a high volume provider. Dr. Russo with Dr. Greeley and Dr. Wattenberg right now. We'll just throw them all in there again. And so we project 2,200 visits. We'd like to see Lori Kohler's visits come up. Maybe Heather's 2,000 goes a little higher and Lori's 2,000 a little lower, but between the two of them, those two providers, we'd like to have them see 4,000 patients a year. We'll still have some patients in the walk-in because we'll be, like Dr. Wattenberg is working in the walk-in. So we will have some patients through the summer months again, and then they'll go to the provider-specific environment. And the specialty, we're projecting it to go up. As we said, we want to see more surgeries, and we'd like to see a higher volume on the orthopedic practice, which Brady and Sean are working on. So again, we get to 10,800, and there's that increase. Any questions from Rich or Shelley about what's in front of us here?
No, thank you.
No, thank you.
Okay. Ethan, okay, everybody's favorite subject. Okay, labor costs. So labor costs, and so in labor here, so I've broken out the two components of the labor cost Shelley mentioned is that overall, the labor is gonna go up just about just a little over $1.2 million. 915,000 of this is an increase in salaries. And then when we look at the increase in salaries, we look at two perspectives. We say, okay, how much of the increase in salaries just came from us adding bodies? And in this case, it's $325,529, you know, fairly rough numbers. And then the other piece is that we're having an increase in the average hourly wage. And we talk about it down below the things that, next bullet down, we talk about what drives our wages up. What drives our wages up is the negotiated union cost of living. And then also the employees that, and this is a smaller amount, it's less than there are people that are still receiving step increases, which currently an employee receives a step increase, which is an anniversary increase. So when they hit their hire date anniversary, month and date, they get a 4% increase until they're at the top of their pay scale step. And there's currently eight steps right now. Like I said, a lot of the employees are hired in at the higher step level, and so we don't have to absorb that as many times. And then the last one is that in another week we'll be bumping our minimum wage pay scale to $18.63 to be in compliance with Senate Bill 525, which was the $25 an hour minimum wage for healthcare workers that fortunately rural hospitals that aren't part of a system, so independent rural hospitals, were able to start at $18 and then go up 3.5% a year until they hit the $25. So all of that, our average hourly wage from estimated this year to budget is estimated to go up $589,000. And these two amounts, so the FTEs represent a 3% increase in our salaries. And the average hourly wage is a 5.64%. So our wages are going up 8.75%. Now, a piece of this is that, as you saw earlier, that our contract labor is going down $159,000. So what's happening is we're budgeting no registry nursing in acute. So we're fully staffed with RNs and LVNs, with employed staff. The ER, we only have a short time, a 3-month registry person, and then there's none after that. We have no registry budgeted or no registry anticipated in lab or radiology. The only place we budgeted for registry, other than that small amount in ER, is in long-term care. Just at the time when we prepared the budget, we were down 3 LVNs and a CNA. So what happens with this is as we're replacing registry with employed labor, we're bringing in higher wage people. We're bringing RNs, we're bringing in, RNs are definitely above our average hourly wage. The techs in lab and radiology are right at or above that. The RNs in ER, same thing, are above. So we're adding higher wage individuals above our average hourly wage to replace even higher paid contract labor. And it's not a 1-for-1 kind of thing. When you do the analysis, is that we brought on Judy and Shanna and everybody have brought on these permanent employees over time during fiscal 25. And so we have a full year of that higher wage in 26 versus partial year in 25. Another one that affects this is Stephanie White. We brought her on as a nurse practitioner last fall, and she comes in obviously at above the average hourly wage. So,
Steve,
yeah,
I have two questions.
fire away.
Okay, so the step increases. So do only the licensed staff get step increases, or does it apply to the unlicensed as well?
Everybody, licensed, unlicensed, union,
Okay.
non-union. I think the only person that doesn't get a step increase is the CEO, because he's the only individual that's under a contract.
Okay, got it. Okay, that was one. That was the first one. And then under the, let's see, it's the fifth bullet there on that slide where it addresses the FTE increases. Why do we have a 2.63 FTE increase in med-surg ED?
That's the elimination of registry, well, basically the essential elimination of registry staff in those two areas.
Okay, okay. And I see a decrease in long-term care of 2.43.
Yeah, that's the unfortunate that this is just a comparison of what we ran in 25 versus what we're budgeting, and when we did the budget, we were down, you know, the three LVNs and the one CNA, and those are 0.9s, so,
Okay, okay.
yeah.
All right. Okay, thank you.
Uh-huh. And so we work our way through the dollars, so our average hourly wage is jumping up pretty substantially, and that's a big jump, and I think we talked through it, is that what we're seeing is a shift in adding higher paid employees and eliminating, like I said, even higher paid registry people. But it's great that we have our own staffing in the patient care areas. I think we're clearly the envy of many hospitals, and you know, kudos to Judy and
Absolutely.
Shanna
Yes.
for doing that. And you know, I'm an accountant, but I get it. I think that, and it's the same thing when you go on the provider side, when these caregivers are part of our team on a consistent or a constant basis. I think that they take, I don't know, the care is the same, you know, they're professionals. But I think that when this is my hospital, I think that translates differently, so.
Yeah.
And I think it's very important, this is my community, this is my hospital, and it's very important to have as many of our caregivers be community-based, or at least, you know, from the area, general area, Susanville, wherever it may be, as opposed to, you know, different state, a different wherever. So I think it's the continuity, because the registry people, they're here on 12 week or sometimes even shorter engagements, and then they leave. And
Right.
so, you know, I think it's nice when a patient sees the same faces. So,
Right. Right.
for better or
Is
worse.
our average hourly wage approximately the same as for PDH and maybe Banner? Do you know?
Is. Shanna takes a look at all of those when we start to do adjustments. She does a kind of circuits the entire area, PDH, EPHC, MODOC, Banner, so that we're competitive in our pricing, in our salary.
Okay.
Yeah, it's one of the components, and this year we didn't do market adjustments, because we had been doing market adjustments. We've been doing market adjustments kind of continuously. But as we set the budget, we felt that our wages were competitive with the hospitals that we would be competing with for staffing.
Okay. Good to know. Thank you. Thank you for tolerating my questions.
Oh, those good ones.
Just a note that Rich has a hard stop at 10:30.
Okay, all right, so then there's the FTE build. Now, there are a couple FTEs we've added, medical staff and human resources. Human resources always was a 2-person department. Shanna came in, got set, and the termination was made to hire an individual to assist Shanna and also to assist medical staff. And one of the ideas of the medical staff person is to try and start working on a succession plan within that department. The in-service position is a half-time position. This may not even happen. It's been offered. The individual that we offered it to has about 2 more weeks to make a decision whether they're gonna come back. If they don't come back, we will not have, will not have the position. We'll absorb it within the rest of the organization. But it had been offered to a person, an RN on leave. And if she comes back, she'll have it on a half-time basis. It's for the nurse education. Finance is my controller, which is an ad. Yay. So one of the reasons it doesn't pencil out is that she'll probably start here 1st of September. And we're hoping that there's a small amount of overtime that we're experiencing related to some of the system conversion issues we've dealt with. We think that this position will help, certainly in the AP payroll side, help eliminate all of that. And so it doesn't equate exactly to a 1.0 or a 0.75, which it will in the future. So those are the 3 positions that are not replacing or supporting an existing position. Those are new positions. Questions, comments?
Where does the physical therapist show up? Is that a contract?
That would be an employee under a provider employee.
Hang on,
So that's not budget then.
hang on a second.
1 second.
That might have fallen out. Hang on. Where? Okay. We budgeted for a 0.75 increase, so. That should be in there. The dollars are in there for sure, so that should be in there. It's an employee position, and we budgeted for them to come on this fall.
Not sooner?
Soon as we get them.
So it just, so everybody knows, we're the one that we were recruiting that was supposed to be here July 18th. Sent us a note that he won't be coming. So we're back in full recruitment mode.
I didn't know it.
Okay. So I'll clean up that slide so it ties out. We're still going forward with that position. We're putting the dollars in there. I might adjust the timing, the arrival times, but I need to get that back in there. I know the dollars are in there. So thank you for seeing that. Okay. Next slide, please. Okay, so here's a little more discussion about the non-labor expenses. Our pro fees medical we're projecting them to go down because we used those 2 locum providers last summer. Although we have Dr. Wattenberg here on a short-term basis, he's not at a locum rate, so we will be seeing some savings there if all things continue along. There's a decrease of 200,000 in pro fees other. There's 2 things in there. We pay that company SCA to help us increase our rate range payments, or the IGT. And, it was, 186,000 in 25. And the way the net numbers look now, we think we're gonna be paying them more in the range of 60,000. There were also the costs associated with doing, the line of credit issuance, and those have gone away. We can talk about it, the board meeting talked about doing the extension on the line of credit, and they want attorney fees that are kind of unacceptable to me at this point, so, we'll have further discussion there, but I don't anticipate paying a significant amount for an extension, if anything. The decrease in the contract labor, 150,000. Purchase service is up, almost 198,000. The big piece of that is the resumption of the MRI service, and we'll be paying the outside company for the first couple of years until we get our own rig. We also went with a new cancer registry vendor, and that has increased our costs somewhat. Supplies, there's some utilization increase. We did, general price increase, similar to last year, what we saw, and it seemed to work out. 7% in dietary, 3% for all other departments. So that's 113,000 in supply expense. The other piece is our insurance in the areas of D&O and EPL, employment practices liability. We had an increase in our loss ratio in that area, and so our cost went up. We also are projecting more utilization, so our general health professional liability, the malpractice insurance go up. Good news is our property insurance went down, so that was a nice surprise. But overall, our insurance is going up $73,000.
Steve,
Questions?
what about the radiology, the professional radiology contract?
Yeah, what we did is, the numbers that are being provided to us by the groups that we've talked to, they appear to be, certainly no more than what we're paying now, and will probably be a savings, so we just went with what we're paying now.
Got it. Thank you.
Yeah. Okay. Moving on, home stretch. Okay, so. In short, the net income loss with IGT, like I mentioned, it's just a slight increase over fiscal 25, just under 2 million to just over 2 million. 1.5 million increase in net patient revenue, 1.15 increase in total operating expenses. So we're about, 370 good there. A little bit of an increase in non-operating revenue. The assessed value in the hospital district continues to rise, so that's good. Here's the one, put on your seatbelts for this ride. So, we're gonna have a just about a $355,000 decrease in our net supplemental payments. And there's a few things working here. So, we are going to see an increase in our net rate range payment of $336,000. The problem or the issue for fiscal 26 is this, up to this point, we had been receiving a little bit of a higher federal matching. So in other words, when we do our IGT and that's turned into federal funding, we were getting a little bit of a higher rate. They're giving us a few percentage more for COVID, and then finally ran out. So this has nothing to do with what's going on in Washington now or the state budget or anything. This is just a matter of that the federal matching went down on all programs. And so that's why we see a projected decrease in QIP of 157,000, that we're thinking that we'll have the same general pool of money. Seneca will get the same allocation. well, I guess I shouldn't say there'd be the same pool of money, but, we'll have the same floor, if you will, of $750,000. There will be a little more money than that, but less, a little more money available, but less than this year. And so we'll see our net amount go down, is what we're anticipating. Now, the HQAF and the DHDP, they're kind of like linked. HQF is going away and DHDP is going to take it over. The DHDP stands for District Hospital Directed Payment. And so what happened was 2023, the program year, which we received funding for in 24-25, was the first year for DHDP and it was the last year for HQF, using the, here you go, using the IGT, using the IGT element. And when the state put together the first year of DHDP, they made an error with a few hospitals and didn't consider long-term care days, which is basically the bulk of what we receive. And so, District Hospital Leadership Forum was able to work with some of the funds and move some things around and held us whole. But in order to hold us whole, they gave us a full year DHDP payment in fiscal year 24-25. Whereas if we would have been receiving, which we did received a very nominal amount for the first half of program year 23, we just would have received a half a year. So we basically got a double payment. And so now when we go into fiscal 25-26, instead of getting two payments under the DHDP program, we're gonna just get one. So that's where our hit is. And that program is also being impacted a little bit by that, the FMAP going down. So, short story long or long story short, the net effect to us overall is that we're going to see a decrease of about $355,000 there. It was good that we were able to, one, get partnership to increase our rate range payment, but again, that was somewhat reduced by the FMAP, but for Kaiser to jump in and put in about $200,000, a little over $200,000 net to us. So it's not like we're necessarily losing anything. We just got, if the HQAF DHDP would have played out, like it was supposed to this year, we'd be probably right on the number. And the increase in the rate range through partnership and rate range and partnership and Kaiser would have covered the loss we would have received. We'd probably be at a break even, but regardless, that's where we're at. And so we take that hit there and it brings us down to our bottom line of $71,751. Is there any questions about that? Obviously the last part, but bringing this thing to a bottom line.
No?
All right, so next slide, Ethan. Okay, so this is where we're projecting that Seneca will be at next week, or a week from today. That we'll have the just under 7 million, 113.75 days cash on hand. Obviously, we need to pay our fall IGTs from that, and then we get the money back, but we're well positioned to make our IGT in the fall right now. And so if we run the budget through, Ethan, if you go to the next slide. So here's how the budget runs through. So here's our cash and cash equivalents that we're projecting at June 30, July 1, 2025. The net income after the IGT, $2 million. We get to add back depreciation of $400,000. We have to make our COP interest funding, and that's, you can see, just over $1 million. That's the sinking fund on covering the interest of the COP interim financing. And after all that, we're projecting that we'll have $8.3 million on hand at June 30, 26, and days on cash on hand will be 129.31.
Good,
Yeah.
And that's it.
thank you. As far as the finance committee goes, we listened to the presentation. Shelley, do you have any comments that we want to bring forward to the board meeting?
Not specifically, just related to the swing program. It is a gamble. I think it's the right thing to do. But it's a risk. Um, I'm I'm very pleased with the day's cash on hand. Project for 6/30 of 26 at 129. But
Okay, as a formal proceeding that we do in this budget, since we never had a budget meeting previously that I've been involved in, and there's just two of us, I would suggest that we just say we heard the presentation, we support the presentation, and we're moving it forward to the full board meeting Thursday for them to approve it. My one area that I would like to see us hear more about, we skimmed over it lightly, is the capital budget. Because I'm a proponent of having a formal capital budget.
okay.
I don't know if Steve could make a little more, give a little more detail about what we plan to do with the capital budget for next year. I know you mentioned they're just small items, but I think we ought to at least approve a capital budget of some kind.
Okay.
Yeah, and spell out what goes into that capital budget currently and
Okay.
projected.
Okay. Can do.
And Jerry, since you run the board meeting, is there anything that you'd like to see us do at this meeting? Any
You s-
formal action?
He's a bystander, but, I would,
He is she's not a member of the meeting, but she's a bystander, right?
it's just of society.
Right.
We'll bring this to the board for obviously motion to approve the budget. And we've taken from the committee, the board members in this committee, that we will provide a capital budget. We have had conversations internally about what would go in that capital budget from a projection perspective. So I think that we're fairly well down that path. We're just gonna formalize it and bring it forward as a formal capital budget, prospective capital budget based upon financial performance. Really, obviously, it's everything is, if we suddenly have two patients in swing and we're doing much better, then maybe
John, this is short notice before Thursday. I just want some mention that at some future meeting, we'd have a more formal capital budget.
Understood. Yep, got it. Steve's written it down for sure. Okay. Anything else, Shelley, Rich, as we begin to close this out? Steve, good job. Thanks.
Yeah, excellent job, Steve. Thank you so much.
Really good. Really.
Yeah, I worked with my fellow chiefs and department managers a lot more this time, so it was good. Much better process. Looking forward to just getting stronger each year.
And Shelley, I do share your concern. We believe that, revenue is the clinic specialty, specialty work. And then I think that swing is ultimately the keys to the castle at this point to really bring that program along. So we share your concerns there. And we are all hands on deck as it relates to building that program back.
Right. I think this presentation, including a capital budget, will tie well into the strategic planning committee also just
It
as a
does,
side
yeah.
note.
Well, and I think a lot of the capital budget requests are specifically related to strategic planning as well.
Yeah, absolutely.
Okay,
Okay.
good. Anything else on item number 4? No, Steve, great job. Thank you so much.
Thank you, Steve.
We'll move to number 5, next regularly scheduled, next regular board meeting announcement, is scheduled for this Thursday, June 26, 2025, 3 p.m. here in the Lake Elmore Clinic, conference room at 199 Reynolds Road, Chester. That's our normal board meeting, our monthly board meeting. Just so you know that I will be attending that remotely, on the phone. If there's nothing else, then we will adjourn.
Very good.
Thank you.
Thank
Thank
you.
you.